after a gap of nearly 3 months, we stopped it in the month of July because of for preparing for the annual conference. And after that, we didn't start because of Puja and other festivals. But let us start with a new format. We will be having 3 talks. One today, where the first talk will be by Dr. Aditya Kapoor. He will be speaking on some interactive ECGs. Then the second talk will be by Dr. Avik Karak. He will be talking on some peripheral vascular disease, a case report. And the third one will be by Arindam. He will present a case, clinical case, and we will be interrogating him as we do in the exams. It is for their preparation. So without wasting any further time, let me request Dr. Aditya Kapoor. He doesn't require any introduction. He is the professor and head of the Department of Cardiology at SGPGI Lucknow. And it is pretty cold there, as it is very well seen. He is wearing a coat and other things. So, Dr. Kapoor, please.
Yes, sir. Sir, good evening, sir. Am I audible?
Yeah, very well.
So I'll share my screen right away. And it's a honor and privilege to be here. And Dr. Shantanu Guha is there. Dr. Soumitra Ray, coordinator, moderators, Dr. Datta sir, Dr. Arup Biswas, Dr. Sura Mukherjee, Dr. Survo Banerjee. So it's a privilege to be in such an august gathering. And when I had spoken to Dr. Shantanu Guha sir, he said that we'll have some interactive ECGs. So I have some good ECGs here in the next 30 minutes, whatever we can discuss. So this is a 50-year-old female who had a chest pain for 4 hours. And this is the ECG which shows a standard acute inferior wall ST elevation MI. Slides are moving, sir? The slides are moving.
Yes, sir.
Are the slides visible, sir?
Yes, sir. They are visible.
Okay, sir. Okay, sir. So if we have
very well visible.
Okay, sir. So standard acute inferior ST elevation MI, you see there is inferior lead ST elevation 3 more than 2. Some depression in lead 1 and precordial lead ST depression as well. So 2 hours later in the emergency, now this is the ECG. Do we have any students who want to tell what is happening? Because now the ECG 2 hours later, same patient, now the ECG shows ST elevation in lead 1 and AVL. And the inferior ST elevation is not visible. Are there any students who want to say something? Sir, do we have any students? Sir, you are muted, I think, Dr. Shantanu.
Sir, you are muted.
Muted. Please don't mute me. I'm telling the technical persons.
Yes, sir.
Arindam, you are here.
Yes, sir.
Why don't you interact?
Hi, good evening, Arindam.
Good evening, sir.
So you see now the ECG shows ST elevation in leads 1 and AVL, and inferior leads it is not visible. So any thoughts on that?
So probably the limb leads has been reversed, maybe mismatched.
Good. So your estimation that leads are reversed. Any guess on what leads have been reversed? You're absolutely correct. What leads? So, Arindam, any guess on what leads? Because normally we have right arm, left arm reversal, which is very common. You know, it shows AVR shows upright and lead 1 is reversed. But what leads are reversed here?
It's probably, sir, left lower limb and left lower limb and left arm.
Excellent, excellent. How did you deduce that? Excellent. So,
Sir,
go ahead. Excellent. You're absolutely correct.
yes, sir.
shall I discuss how did you deduce that? Because your guess is absolutely right, and you have made the correct diagnosis. I'm so happy that you made the correct diagnosis. So for those the students who are listening, Arindam is absolutely spot on. He says that the leads are reversed, and he says that left arm and left lower leg have been reversed. So how did you come to this conclusion? If you see lead 3 is completely inverted. And look at lead AVF. AVF is looking like AVL, the original AVL. So now, Dr. Goa, I've interacted with him in so many ECG sessions and other sessions. He always teaches that your analysis has to be like maths, like vector for ECGs. So we will show you this diagram now. So if you see, this is the standard, this is lead 1, this is lead 2, lead 3. So now if you reverse the left arm and left leg, what happens is that lead 3 will invert, because left arm is here, left leg is here. So lead 3 will invert. And since right arm is here, so right arm and left arm is lead 1 normally. So lead 1 will become like lead 2, and lead 2 will become like lead 1. Easy enough to understand. And if you look at the augmented limb leads, since the left arm and left leg have been reversed, AVL becomes AVF, which was happening in the previous ECG, and AVF becomes AVL. So broadly speaking, what will happen is lateral will become inferior. So a carry home message, when this will happen, lead 3 will become completely inverted, and always pay attention to the P wave in lead 1. P wave in limb lead 1 is always less than the P wave in lead 2 normally. But when this inversion happens, since lead 1 is becoming like 2 and lead 2 is becoming like 1, the polarity or the voltage will differ. So I'll explain what I mean. We'll again come to the first ECG. So this was the original ECG, acute inferior ST elevation MI. And look at the P waves in lead 1 and 2. So P wave in lead 1 is always less than the P wave in lead 2 normally. So when as Arindam rightly said, when the left arm and left limb get reversed, not only will lead 3 become inverted, note the P wave in lead 1 now. So the P wave in lead 1 is now bigger than the P wave in lead 2. So this is a very, very important message. And this happens really in the emergency, in a busy emergency or a busy ICU. The sisters will reverse the electrodes, or the technician might reverse the electrode. And you might wonder what has happened to the inferior and the lateral. So lead 3 totally inverted, and P wave in lead 1 more than the P wave in lead 2 is a clue that left arm and left leg have reversed completely. So this is one first message. And Arindam, good show. Your diagnosis was correct. The interpretation has been done by me. So good show. So this is what happens. And now when you put the electrodes back to normal, it is back to inferior wall MI. So left arm, left leg reversal, very important in diagnosing acute coronary syndromes. Pay attention to the limb lead 3 and pay attention to the voltage of the P wave in lead 1 versus the voltage of the P wave in lead 2, right? Another patient, 62-year-old, hypertensive, diabetic for 5 years. He has had left arm discomfort for about 4 hours now. And this was the ECG which was sent by WhatsApp to a cardiology colleague. So this is lead 1, lead 2, lead 3, AVR, AVL, AVF, and V1 to V6 are on the other side. So Arindam, you want to have a go, or is anybody else there? Because Dr. Guha sir also wanted this to be interactive, so you needn't always necessarily be right. But what does the ECG grossly show? Patient is hypertensive, diabetic, and is having some discomfort.
Again, the same thing, isn't it? The inferior leads are all inverted and AVRs are all upright.
Dr. Ray, good evening.
Yeah, good evening, Dr. Kapoor.
So, sir again says that the leads are inverted. It's right. So 2, 3 AVF, they are inverted. But if you see, AVR is upright.
Yes.
Lead 1 is isoelectric. So something odd is happening. This patient was about to get fibrinolysis, but when the ECG was sent to us, we told them that something is amiss, because as Dr. Soumitra Ray also says, correctly that if you see lead 2, 3, AVF, they're all inverted and they almost look like each other. And even the P waves are inverted here. And the odd thing is that somebody might say it's an inferior wall MI with a low atrial rhythm. But the odd thing, as Dr. Ray also said, AVR is upright, AVL is upright. Lead 1 is isoelectric. So many a time we don't pay attention to isoelectric lead, key connection utar gaya hoga, something like that. So if you see the analysis of this ECG now, which looked like a standard ACS, lead 1 is isoelectric, correct? Completely negative leads in 2, 3 AVF, which sir also pointed out. And third thing is upright AVR and AVL. So let us go back to our diagram now. So this is our standard diagram. So how will you see over here? This is left arm, right leg, left leg. So you remember the lead 3 over here was inverted, right? So how will lead 3 get inverted? We have just discussed. So this is how the lead 3 will get inverted. Now the important thing is that lead 1 was isoelectric. So the lead 1 will happen to be isoelectric only if you switch the right leg and right arm, because now the right arm comes here, and when the right arm is on the right leg and the left arm is here, so they will record equal potential difference. So left arm and right arm, which is lead 1, will become isoelectric if you change the limb electrode. So not only is the upper limb electrode reversed, but the lower limb are also reversed. So it's a completely topsy-turvy ECG. So lead 1 becomes isoelectric. So, and if you see here now, so this is what happened. Left arm, right arm here, left leg, right leg here. This explains this ECG completely. Lead 1 becomes isoelectric. Lead 3 becomes totally inverted. And since leads 2 and AVF and lead 3, they are all recording the potential difference across left arm and left leg, they all appear identical. So it's a dramatic ECG. And of course, AVL and AVR will appear identical. And when we told the guys over there on phone that you record a normal ECG, bilateral upper and lower limb reversal, so it's completely normal ECG. So Dr. Ray completely, he diagnosed it absolutely spot on. So if you see again, Arindam, and for the students' benefit, I'll show this. What sir picked up initially, that 3 leads are negative, they appear identical. AVR and AVL are identical and upright. AVR cannot be upright in a normal person, and 1 is isoelectric. So we in fact had never encountered this before, and we actually happened to report this as a topsy-turvy ECG with a pseudo-infarct pattern. So quick way to diagnose such a bilateral arm leg reversal is if there is isoelectric lead 1 and, as sir also pointed out, inverted lead 3, which looks identical to 2 and AVF. So multiple leads looking negative isoelectric, and an isoelectric lead 1 will tell you it's a reversal. So before we quickly move on, just quickly summarizing the reversals, because this is such a fantastic thing and very easy to diagnose if you have a left arm and left leg reversal. We have discussed this. So left arm, left leg, always draw these diagrams. So lead 3 will become inverted, lead 3 becomes inverted, and the P wave in lead 1 is more than the P wave in lead 2. And 1 and 2 will become interchanged. What happens if there is a right arm and left leg reversal? So right arm and left leg, like this. So, we, after this 1 or 2 cases, we actually recorded multiple ECGs like this so that we remember this and made some diagrams and kept it in the ICU. So when this happens, 1, 2, 3 AVF, all will get inverted and lead AVR will be upright. When right arm and right leg, so you see right arm, right leg goes up here, they reverse. So what happens here? Arindam, I'll just ask you once. So right arm idhar chala gaya, right leg idhar aa gaya. This is left leg, right? So this is left leg. So which lead will become isoelectric now? Arindam, left leg and right arm. Which lead record? Left arm, left leg or right arm में कौन सा lead रहता है normally?
Left leg and right arm. It will be the
lead
2.
Lead 2. Lead 2 will become
Lead
flat.
Lead
Correct.
2.
Easy to diagnose. So if lead 2 is flat, you can suspect this. And of course, with this, one will become inverted. So there are multiple permutation combination you can play around. And one thing important over here, just forget about this. Arindam, what will happen if you do this? Left leg and right leg reverse. Left leg idhar aa gaya, right leg idhar aa gaya. Will it change the ECG?
Yes, sir.
No, it will not change
No.
because
Yes,
dono hi isoelectric potential pe hai na. So this
Yes,
will not
okay.
change. So this is the only lead reversal which will not change. So these are lead reversals. So do not ignore isoelectric leads. Pay attention to leads with inverted PQRS, as Dr. Ray also picked up. So don't ignore these subtle things, because sometimes you can make misdiagnose ACS. You can thrombolize patients when they are not in the need of thrombolysis. So this is one part, lead misplacement. So another patient, third case, 40-year-old lady who was having hypertension. Blood pressure was around 140/95. Recurrent syncope. She was in fact referred for an ICD. So I think Arindam is the only scapegoat here, is it? Or anybody who wants to. So
There should be some other, Arindam,
Yeah.
any other student here with you?
QTC prolongation is there, isn't it?
Aditya or
Dr.
Vipul, anybody?
Dr. Soumitra Ray is leaking all the answers.
QTC should be corrected.
Corsets.
So sir has given
This
you a
is a-
clue. No? He says
Yes,
that
sir.
you can see a torsades type
Sure.
like ECG
It's
here
a
and
polymorphic.
polymorphic. And sir has also given you a clue that there is
There's a
a
QT
long
code.
QT, correct? So she was having hypertension, recurrent syncope, referred for an ICD, and of course for this ECG, for this torsades, when she was cardioverted. So this was the ECG in the IC on the next day. So what are your thoughts now? Just describe the ECG for us.
So this shows sinus rhythm with
Was the electrolyte done, Dr. Gupta?
Excellent.
Dr. Kapoor,
and
electrolyte?
there is also presence
Excellent,
of
sir. I'll
U waves.
just
There is
come
U
to
wave.
that.
So there might be, so
There
there
are
is presence of
U
U
waves.
waves.
The CKD could have been a probability there because CKD leads to this kind of tent and desert type of configuration with flattened T, wide space T, and tall
Yeah.
R, etc.
So the ECG showed this sinus bradycardia sort of a rhythm, and there was a QT prolongation and very prominent U waves in the precordial leads. And as sir rightly said, when we did the potassium, it was 2.7. So Arindam or any other student now, of course, ICD is out because you have a reversible cause now. So by this,
Sir, besides potassium, we want also calcium and magnesium level because whether the patient is having CKD, that we have to
UAF. UAF is very prominent.
very prominent U waves, potassium was 2.7 and creatinine was around 1.3, 1.4. So what I was trying to ask you, Arindam, if somebody shows you this slide in the exam, she has hypertension and she has potassium is 2.7. She's not on any diuretic. Any cause you can think of?
Con syndrome.
Absolutely correct. Very good. Very good. So in fact, this was suspected. In fact, she was having hypertension, recurrent syncope, potassium 2.7. ICD, of course, was out. So when a CT and the aldosterone renin ratio was done, it was markedly elevated. There was a right cortical adenoma and it was removed and the patient recovered. And again, a treatable cause of aborted sudden cardiac death. So whenever you get hypertension, syncope, or you get syncope, and patients are referred for ICD, as sir also pointed out, always do an ancillary lab workup. You might get some reversible cause, right?
Sir, may I interject once before, because on this topic, I want to give a word of caution.
Yes, sir.
Very recently it happened. One of my very close relatives was in Delhi, an elderly lady, presented to the emergency of a very famous cardiac hospital in Delhi with syncope. And they did the ECG and my cousin sent me the ECG. It was a clear 2:1 AV block. I say, don't worry, they will immediately put a temporary and perhaps a permanent tomorrow because there is no other reversible factor. And 5 minutes later, he said, no, the emergency doctor is saying it's an UAF and he will keep in the emergency for observation. He is sending the potassium and he will correct the potassium, everything will be okay. I said, please give the telephone to the emergency officer. I argued with them and he said, no, sir, I know what I am doing. Let me do my business.
Oh my God.
So I was very scared. My aunt will die tonight. So I had to call up the consultant. Fortunately, I knew the consultant of that hospital. And he said, oh my God, I am ashamed of my department. So he took over at 12 o'clock midnight. He took my aunt for temporary finger. So too much of UAV is also not good. So, so what I would tell, if there is
Soumitra,
any
you know better.
confusion, any
Soumitra, my
confusion, just
comment
put a
to
pic-
this is you know better.
You
you know better. No, Arundam, jokes apart. You just put a piece of paper, tell all the juniors that just put the marking PUP and see whether they're coming at regular interval. If
Yes.
they're coming at regular interval, it is not PU, it is PP. So please see that the interval is very important. A piece of paper and a pen will do the job, just to see the gaps between the two, whether they're regular or irregular. I think this is a very, very simple thing, but people can miss and it can be fatal.
It can be fatal. I think that's a very important carry-on message which you give, that you put take a piece of paper and mark it out with a pen, because we always used to do it. I don't know whether the current generation does it, and it's a very, very important thing, because sometimes you can mistake U waves, although the morphology is different, but you should always mark it out with a paper. I think that's great. That's a great message.
Dr. Kapoor, may I add one thing? Besides plain piece of paper, the end of the ECG strip where there is no complex, that helps us a very good scale. We often used to cut it or tear part of this and used to mark these waves and regularity check.
Absolutely, absolutely. Agreed, sir. Agreed. Shall I go forward, sir?
Yeah, please.
Okay. So another case, if you see the 63-year-old male COPD, coronary artery disease, known case, hypertension, diabetes, comes to the ED with shortness of breath, and a central line was being placed by the anesthetist. So right IJV line, and after that she became hypoxemic, developed some more shortness of breath and went on a ventilator immediately. And an ECG was done, which showed this. And the ED guys called up the cardiology resident and wanted them to activate the lab straight away because the ECG showed these changes. So Arindam, supposing you are called, Arindam se hi puch rahe hain bar bar, because I don't know any other name. So Arindam, supposing you get called for this and this is the ECG, this is the history. So what would you do now? Arindam is there?
Yes, sir.
Okay. Sorry, tumhi se puch rahe hain, but you are scoring well and you are doing very well. So what would you do?
Look at lead 1 and lead 3.
So, you can answer. I mean, there are no rights or wrongs in this. I mean, sometimes the decisions, would you rush the patient to the cath lab, or would you do something else?
So there might be some pneumothorax also, because of patient has been done a central line, also intubated.
Good.
That might have shifted the heart and caused this.
Good. So again, if you spend some time on the clinical problem, you will probably get to the answer. So ECG shows these ST elevations which are suspicious, but looking at the clinical context, a pneumothorax is highly likely. So since the patient was already in the ED, it's not too difficult to get a chest X-ray while the cath lab was being activated. So activating the cath lab is not the incorrect decision at all, but an X-ray was done which revealed a right pneumothorax. And of course, now you won't activate the cath lab, or you won't do any thrombolysis or of course PCI. So a chest tube was put, and about 30 minutes later, the ECG is completely normalized. So the intention of showing such ECG is that, keeping the clinical correlation in mind is very, very important. And such kind of funny STT elevations can happen. But again, if you look at the clinical context tells you that, It happens following a right IJV line. So activating the lab is not a bad decision at all, but always do some ancillary investigations, even auscultation. So I don't know whether auscultation was done in this case because I don't remember, but an X-ray was available which showed a pneumothorax and the changes completely normalized. So the intention again to show is that changes like this, dramatic changes like this can happen in respiratory problems also. And before we move to the second segment of these ECGs, I'll just show you a related ECG again. So this looks like a standard ST elevation MI, isn't it? 2-3 AVF shows ST elevation. And in fact, there is some hint of an ST elevation in V1 as well, and reciprocal ST depressions, tachycardia. So this, when the history was taken, this was again a lady was admitted to the ED with dyspnea, cough and wheezing. There was no chest pain. So, but again, chest pain may not be there in females, or in some patients, they might deny a history of chest pain, or dyspnea may be an anginal equivalent. So rush to the cath lab, troponin 0.08, echo normal. What would you do?
If she's rushed to cath lab, perhaps we have to do a cath anyway.
Sorry.
Otherwise, we have to.
Sorry,
If
what
she's
is it?
rushed to the cath lab, perhaps you have to do a cath anyway.
So the troponin was borderline, and in fact, an X-ray was done because the main history was dyspnea, cough, and wheezing. So huge, again, a huge tension pneumothorax. So chest tube was put, and no, the
I
ECG.
think, Dr. Kapoor, it shows that we have to see the patient. We have to use the stethoscope. I think that is the message you are giving.
Because
just not the ECG and echo and other things. I mean,
because as you rightly say, these things cannot be missed if you auscultate the chest.
Absolutely, yeah.
So the reason for showing that is what Dr. Guha was also telling me. You know, we should have a holistic approach to patients and show some examples which
absolutely, yes.
So again, 2 examples of pneumothorax I wanted to show, because sometimes a lot of explanations put forward. I myself am not clear why these happen, but literature reveals that it could be a pressure on the heart, pressure on the coronary vessels, or hypoxemia, which precipitates a type 2 MI, elevated myocardial oxygen demand, increased intrapleural pressures, or cardiac rotation. But whatever it is, as Dr. Ray also said, it can happen. And whenever you are bringing a patient to a lab or admitting any patient, look at him in clinical detail, take a history, auscultate, because many a times we don't even put a stethoscope before getting these guys to the lab.
Absolutely. We don't carry stethoscopes. Tell me
In
from
this
your
context,
experience.
I would share my experience. A patient was admitted in the evening at medical college. ECG showed ST elevation. Clear as definite this pattern of ST elevation, convexity outwards. We thought, as usual, that is maybe an infographic on the history. He said that he is having that pain for the last 3 days. I was surprised. There was no evolutionary changes, only ST elevation. That raised the suspicion. Did an echo, there appeared to be some mass. We did a cardiac CT. There was a mass which was pushing the heart, a mediastinal mass pushing the heart and creating this type of an ECG changes. And echo also showed almost a similar sort of a thing. So ST elevation doesn't mean always it's an infarct. There are several reasons why one can have an ST elevation. And this particular case was published in Indian Heart Journal as a case report. It was just since you have shown 2 cases of pneumothorax, right? My experience was a tumor can also produce this type of an ST elevation.
So both are pushing. So pushing actually can cause ST elevation for whatever reason. Dr. Kapoor, from your experience, it is said theoretically that in an STEMI or an MI, echo changes come before ECG. Do you believe that?
Sir, actually, Theoretically, it can happen because rise in LV-EDP can precede ECG changes and it can lead to regional wall motion. But to be very honest, neither are we able to pick it up because we don't do an echo that early, and the ECG is the first investigation which is done.
Absolutely. Absolutely. Yeah.
So,
Dr.
Mitra, what you
Kapoor,
say
I think
is-
another note of caution, because in STEMI guideline, it is said that once you see ST elevated, go for thrombolysis. But, and this is a but, that without waiting for other investigations. But clinical correlation is always important.
Absolutely.
All said and done, ST elevation, don't run for thrombolysis, jump, because time is always muscle and money, whatever it is.
Absolutely.
But one should have a clinical correlation. At least that doesn't take that much of time.
Absolutely. I have had cases of missed aortic dissection
Yes.
as elevation MI.
Yes.
Simply, you didn't feel the pulse in 2 hands
Yes.
and you lost the patient by giving streptokinase. Long time ago, but it happened. I saw it.
So, do I have time to show one last ECG?
What-
Because I think
Just
we are-
in this context, another discussion. I have seen patients denied the benefit of thrombolysis because his TROP-T kit was not collaborating.
Yes. Yes.
So TROP-T kit needs the maintenance of a good cold chain. Otherwise, it may be leading to false positive or false negative. So he had classical things. He had classical ECG. Despite that,
Yes.
he was not given the benefit of thrombolysis as kit was not matching. So again, a note of caution
Too much.
that don't depend upon the kit always.
Yes. Yes. Shall I show one last ECG, sir? before-
Please. Yes.
One last. So this is a monitor of a, not a monitor, but a rhythm strip of a 21-year-old guy who had shortness of breath, dizziness, and some pre-syncope. Blood pressure was 90, and there's an audible systolic murmur over the precordium. So this is the V1 lead, and so does it look like a SVT, VT? Can't say. If somebody asks me, I would actually say that it looks like a VT to me. And I think most of us would perhaps say it's a broad QRS rhythm, looks bizarre, and could be SVT, but most of us, I think, would vote for a VT.
No,
What
can't say.
Left-sided pre-excitation also.
Yeah, so broad QRS rhythm, Dr. Soumitra Ray is smiling enigmatically. Dr. Vijay Pandey, hi.
Yes.
Hi. So broad QRS rhythm looks regular, and anything could be. So now we have V1, V2, and V3. So my point was, if you have multiple leads, if you see V3, you can clearly mark out the QRS.
QRS, yes.
So now if you mark out the QRS in V3, you can clearly identify the P waves in lead V3 and V2.
Wow.
And match it with V1. These are the P waves. So this was the 12 lead ECG, which now shows actually a atrial flutter. And
Classic.
for the students, now this is the icing on the cake. The patient has a systolic murmur. He has a rapid atrial arrhythmia, and this is the X-ray.
Wow.
So what is the diagnosis? Arindam? Systolic murmur, young guy, multiple heart sounds, massive cardiomegaly.
Abstains.
Abstain, absolutely. So again, the carry home message is systolic murmur aa raha hai, young boy, unlikely to be VT. It could be VT. And never make the diagnosis of an arrhythmia based on a single lead. So you have to have multiple leads. If you have multiple leads, again, clinical correlation.
Good.
So that's it, sir. My 30 minutes are over.
Excellent. What a fantastic 30 minutes.
You have you
Excellent
told me
show,
that
Dr. Kapoor. Excellent
other
show.
assignment.
You deserve a
And
big
if
clap of
possible,
hands.
please come back and join. If it is
Okay, sir.
possible,
Yes, sir.
on your part.
Sir, I will try my best because I'll be in the Gadi only, and I will try my best. Thank you.
If possible, just please join and interrogate these students in their quiz presentation.
So
Thank
Dr. Kapoor, usually just look into the ECG sessions and don't have anything because I don't understand anything. But you have brought such ECGs which even I could understand. So it is really, really good. I mean, I look forward to attend more of your sessions, so I get a bit of encouragement
No,
rather than depression.
no, no.
Okay.
I am always
you.
privileged to be with you.
Thank you. Thank you very much.
Thank you, sir. Thank you.
Chief complaints of breathlessness on exertion for last 6 years, palpitations for last 3 years, and chest pain on exertion for last 1 year. The patient was in his usual state of health around 6 years back when he developed breathlessness, which was incidence in onset, gradually progressive. Initially, he felt breathless on his regular activities like climbing more than 2 flights of stairs, which was NOHA class 2, and has progressed over 2 years to a stage where he felt breathless even on his routine activities like bathing, climbing 1 flight of stairs. So much so that he had to change his profession and become a fruit vendor. Over the next 1 year, his symptoms deteriorated further and became breathless even at rest and had to use 5 to 6 pillows to lie comfortably in bed. There were nocturnal episodes of sudden onset acute breathlessness about 2 hours after going to sleep, which made the patient get up and with intense suffocation that would get relieved by sitting upright and legs hanging by the side of the bed. Suggestion of PND. There is history of cough with blood tinged.
Arindam, are you now posted for DM or DNB exam?
Yes, sir. The DM.
In which year?
Sir, second year. I will about to appear for the exam.
Okay, okay. We'll be asking something about PND, okay? Now, not now, later on. Okay, go ahead.
Yes, sir.
Go ahead.
So there is a history of cough with blood tinged expectoration for last 1 year and with 3 to 4 episodes without seasonal variation or associated wheeze. The breathlessness was also associated with bilateral pedal swelling, which was noticed around 3 years after onset of symptoms. Swelling was painless up to mid calf and reduced partially on limb elevation.
Is there any other student who can discuss about PND? No.
And there are some. Aditya, you are there?
Yes, sir.
You discuss up to whatever Arindam has said till now.
Yes, sir.
What is the interpretation of that? He has not completed, I know.
Yes, sir. So the interpretation, basically the patient is having dyspnea on exertion, which has progressed from NYHA class 1, 2, 3 in the past 2 years. It has started 6 years back, but has progressed over
Was
past 2
class
years.
1, why did you say?
Class 2, sir. It started from class 2. Yeah.
You say class 1, don't say that.
What is class
sorry,
1?
sir.
What is class 1? Aditya, define what is class 1.
The class 1 is when the patient is having symptoms of fatigue, chest, angina, breath, dyspnea, or palpitation on mode. Sir, at
Any patient having
Aditya,
this.
the exact definition is patient is having a cardiovascular disease.
That starts
no-
with starting.
sir, no
then,
limitation.
no,
Sir-
you remember this always remember patient with heart disease. NOHA
Yes, sir.
classification is a patient with heart disease. You start with that.
And
Okay.
patient
no
is not
limitation of
having symptoms on ordinary activities.
Yes, and no limitation of physical activity on
Arindam has come back.
Exactly. Say it that way.
Yes, yes, sir.
Arindam has come back, it seems. Arindam, you are audible.
Yes, sir. The palpitation not associated with chest pain and the palpitation. The patient also complained of palpitation, which was initially exertional, felt as pounding sensation in chest, regular in nature, relieved after some time on taking rest, not associated with chest pain or syncope or any post-palpitation diuresis. The palpitation is felt for the last 6 months intermittently, even at rest, and these episodes were associated with shortness of breath. Regarding chest pain, the patient also complained of chest pain for last 1 year, which was exertional, retrosternal, poorly localized, constricting type, radiating to the back, relieved on taking rest, associated with sweating and shortness of breath. There were episodes of giddiness on exertion for last 1 year without any definite loss of consciousness. Regarding the negative history, there is no history of any hoarseness of voice or difficulty swelling. So no history of any prolonged fever, or skin lesion, or joint pain. No history of any limb weakness, altered sensorium, slurring of speech, pain in the extremities, or blackening of the fingers. Past history, no history suggestive of acute rheumatic fever in the past.
Arindam, I will not discuss, but just a note of caution regarding this negative history.
Yes,
The
sir.
examiner might ask in future why these negative histories were taken and why they are linked to this particular
Why they are
patient.
important? Yeah.
Why they are important.
Yes.
Okay.
Yes, sir.
Please
So to rule
carry
of-
on.
Okay, we'll ask you to summarize your case. Quickly, you just go through and summarize, then we'll ask you questions.
So there is no history of such acute rheumatic fever in the past, no history of any tuberculosis in the past, no major surgery in the past. Treatment history, the patient has been on oral medications for last 3 years, for which increased his urine output. He is not on any monthly injections, and he is irregular with medications. Family history, born out of non-consanguineous marriage, married with two children, no family history of any heart disease, no similar illness in the family. Personal history, non-hypertensive, non-diabetic, ex-smoker, mixed diet, appetite reduced for last 1 year with disturbed sleep, increased frequency of urination, and bowel habits are normal.
So go to the summary.
So a 40 years old non-hypertensive, non-diabetic male presented with a history of exertional dyspnea, which has progressed from NOHA class 2 to class 4 over a span of 6 years with associated PND and ophthalmia, along with bilateral pedal swelling, along with hemoptysis and palpitations for the last 3 years, which is mostly exertional, along with history, exertional chest pain for last 1 year, with repeated hospitalization for dyspnea without any history of rheumatic fever or features of compressive symptoms, infective endocarditis, or any embolic phenomena.
So what do you think the case to be? So what is the interpretation of the history? That is what I was asking Aditya. I'm asking the same question.
So since the patient presented with breathlessness and which is also associated with PND, so very likely it is valvular heart disease.
Why valvular?
The
patient
the breathlessness
presenting with,
initially is analyzed. Breathlessness likely to be of cardiac origin.
What is the present class during presentation? Because a patient may hover from class 2 to 4 and may not be always stable in a particular class. What is the present class?
Present class on treatment is class 3, but when he presented to us, he was in class 4.
So from 3, he went to 4. How is the onset? You have given about something about progress, but
Yes,
what
sir.
is the onset?
Onset was insidious in onset, sir.
Okay, somewhere you mentioned that. Yes, Dr. Guha was asking you about the interpretation.
So what is the interpretation of this thing? The patient is having a left-sided heart failure,
Yes,
firstly, which progressed over a span of 6 years, and
Yes.
presently and reached class 4. Patient was in overt failure. You said 5-6 pillows were required. Patient was orthopnic and other things. So there are definite evidences of a left-sided heart failure.
Yes, sir.
Also, you said there are pedal edema.
Yes, sir.
There were pedal edema and suggesting perhaps there is an associated right-sided heart failure as well. We'll look into the cause. Other than that, you said about 2 things. One is palpitation, another is chest pain.
Yes.
Palpitation, you said whenever it was paroxysmal, and whenever there was palpitation, patient's breathlessness increased. That is one thing.
Yes,
you said.
sir.
What is the cause of this palpitation?
So the cause of palpitation initially might be there is some associated regurgitant lesions also. Initially, it was a volume overload type of palpitations, but later he went on to develop a palpitation even at rest. Very likely he has developed some sort of arrhythmias.
So
Arrhythmia, what type of arrhythmia will produce it?
One thing, in that case, you have to inquire about palpitation in more details and enlist that. Whether it is pointing towards arrhythmia, whether it is pointing towards volume overload, tachycardia, or both, or multiple reasons. And the idea, Professor was asking the question that interpretation, and whenever you talked about valvular, he objected. The meaning is, at this phase, you are not supposed to know about the, or not to discuss about the findings. And without finding, just from the history, it is rather leading to heart failure for whatever reason it is. So we can't say more. Okay. So that is why he asked this. Yes, you go ahead with the
Go ahead.
first question.
Sir, can I interrupt? Dr. Arindam Mitra?
Sure.
So you discuss something and always focusing on valvular heart disease. So why you are not bringing any cardiomyopathy in your differential?
Exactly.
Repeat question.
That is exactly
Because you
what I
did not
wanted.
examine the patient, and your history goes quite well with the cardiomyopathy as well. So why you are not telling anything about the differential?
So dilated cardiomyopathy is one of my differentials, and also with chest pain also.
Not only dilated cardiomyopathy, any cardiomyopathy have different stages of this thing. So cardiomyopathy as a whole, it may be dilated cardiomyopathy, something else at the end stage, everything, all the cardiomyopathy will be like dilated cardiomyopathy only. So cardiomyopathy, I feel, will be a very important differential in your case, from history at least.
Rightly so. Rightly said.
Sir, may I, sir, may I ask something? I am Dr. Dipankar.
Sure.
Hello.
Dipankar, go ahead.
Sir, I'm just asking. He said there is no history of rheumatic fever. So then, how can he account for the stepwise deterioration of the patient, going from stage NYHA class 2 to 3 or class 4, whatever? So how can he account for that? That is my first question. And the second question is that PND continue. Now, once we all know that once the rheumatic fever becomes chronic, and there is decrease in the incidence of PND with progression of the rheumatic heart disease. So I'm asking these two questions.
Sir, regarding the first question, about 50% of the patients do not give definite history of any rheumatic fever. And also regarding the progress of the disease, there is a quick progression. So there might be some multivalvular involvements. The patient might have developed some.
You may always get history of rheumatic fever, but when the patient is deteriorating, you must always suspect, because he's not on a monthly penicillin prophylaxis. So
Yes,
that
sir.
you must consider. And what about the second issue? Keeps on having PND even at 6 years.
No, so the incidence of PND has decreased. It was initially he felt around 3 years back, but after that he has not been completely.
Okay. Thank you. Yeah. Okay, go ahead.
You discuss about the palpitation a bit.
So the palpitation initially appears to be like volume overload type, and it was.
What do you mean by that?
The patient initially felt as a pounding sensation in the chest. It was mostly exertional, regular in type.
Arindam,
So an
in case of
palpitation.
regurgitant lesion, as you are talking about palpitation caused by regurgitant lesion, then you have to correlate with breathlessness. Usually, when it is a stenotic lesion, we do have breathlessness at the outset. Otherwise, breathlessness happen when the regurgitant lesion is quite advanced. So, if you are thinking about valvular lesion as a differential diagnosis, you have to think about mixed lesion. Okay.
Yes, sir.
The chronology does not fit a pure valvular regurgitation, because the patient became dyspneic first. Dyspnea progressed, and then the patient developed palpitation. So this actually doesn't fit with the usual chronology of a regurgitant lesion. Arudha, whatever he said is correct, that initially patient gets palpitation, and after that patient gets dyspnea after quite some time. So maybe a mixed lesion if you consider it to be rheumatic, or it may be something else. We don't know yet. Carry on.
So we will go to the examination.
No, what is the differentials from the history? One,
So the differentials I likely to consider valvular heart disease as my first differential with likely an LV inflow type obstruction with along with some associated regurgitant lesion and along with some
you specify. If you are telling valvular, you specify. What are the things you are thinking?
Mitral stenosis.
One is mitral stenosis. It doesn't explain everything.
Pure and isolated mitral stenosis or something else?
No, so there will be associated something else as the patient also
give example.
Any regurgitant lesions like aortic regurgitation or mitral regurgitation.
Yes, so it could be a combination of multiple reasons. Okay.
And also since the patient also complaining of chest pain with associated giddiness, so likely LVOT obstruction in the form of aortic stenosis.
So, but you are bringing in mitral stenosis, aortic stenosis, and regurgitation, maybe at mitral, maybe at aortic, whatever, or both.
Yes, sir.
Okay, that is one differentials. Anything else?
Anything else?
You say dilated cardiomyopathy. Does it explain the anginal pain you are talking about? So, can it be an hypertrophic cardiomyopathy? Is it possible?
So there is no family history is not very significant.
Not necessarily. In how many cases you get it? What are the other main points?
There is no history of any syncope or
a history of syncope is not there. Okay, but anything else? Syncope will be there in aortic stenosis as well.
Also, the chest pain is.
Chest pain can be there in HCM.
And also the history of PND and orthopnea is and the rapid progression is.
All the symptoms, whatever you have said, can be there with HCM as well, but not in the way, in the sequence you have mentioned. Arindam, একটু তুমি জিজ্ঞেস করো এক সেকেন্ড।
Sir, may I ask a question?
Somnath, yes, Somnath, please.
So, Dr. Arindam, can you bring ischemic heart disease with LV dysfunction in your differential diagnosis? And if so, then what are the suggestive points? And if not, then what are the against point for your diagnosis for ischemic heart disease with LV dysfunction?
Since considering the patient's age and absence of any major risk factor except for smoking, and since the breathlessness has preceded the chest pain, so I would go against ischemic heart disease at this given the following symptoms.
May I interrupt, Dr. Arindam Mitra? Tell me the prevalence of acute, STEMI in India, less than 40 years. 25% of STEMI in India happens in individuals who are less than 40 years of age. Create Registry has told us that. We get plenty of patients, 30, 32, 35 years with multivessel disease, LV dysfunction. So only if you consider age to be excluding factor for ischemic heart disease, I will not agree.
Arindam,
patient is a smoker.
Yes. So besides that, the risk factors always do not corroborate with ischemic heart disease.
I fully agree, sir.
Age is not an antagonistic point. Absence of non-risk factors is not an antagonistic point. This is happening in India. But your only point is breathlessness happens earlier than chest pain. In case of ischemic heart disease, there is a reverse happens. And that also starts usually with, exertional chest discomfort. So you may say like that, it remains always a probability due to the incidence and prevalence of this ischemic heart disease going on. But the probability would come in third and fourth phase.
Arindam, Dr. Pandey, one point I think I will disagree. In India, the incidence of acute myocardial infarction below the age of 40 overall, including all the registries and the data, is little over 10%, not 25%. CREATE has given a higher picture, I know, but
that 10 to 25% is the available data. 10 to
Shantanu, we have a lot
25%.
more.
Overall is
Mice to go ahead. It's only the examination has not started.
Carry on. Arindam, please.
Yes, sir. So regarding the general physical examination, patient was alert, conscious, cooperated, oriented to time, place, and person.
You tell the salient points. Tell the salient points only.
Salient points is patient has a mild pallor and sinuses curving, icterus is absent. The pulse is 82 per minute, irregular, variable volume, mostly
You
low.
didn't talk about edema.
Edema is absent at present, sir.
Edema at present is
But
absent.
edema was
During
present, you
presentation,
say?
it was present.
So during there was history of edema, and on presentation also the edema was
Swelling of
present.
feet was there. Now it is not there. Okay, fine.
Yes, sir. After treatment. Yes.
Go to the next page. Go to the next. Yes.
Yes. So the pulse is 82 per minute, irregular, variable volume, mostly low, without radioradial or radiofemoral delay, with normal condition of arterial walls. All the peripheral pulses are equally palpable. Epicocarotid delay is present. Blood pressure, right upper limb 100/70, left upper limb 98/66, left lower
One
limb.
interjection. You
Yes, sir.
said it is irregular. What type of irregularity it is?
Irregularly irregular, sir.
That should be
Irregular,
mentioned.
irregular or completely irregular. What does it mean?
That should be mentioned. In that case, you will avoid a number of questions.
What does it mean? Completely irregular or irregularly irregular? What does it mean?
Irregular is likely in some atrial fibrillation.
No. What does it mean?
Oh, there is no discernible rhythm in the pulse.
One is rhythm, another is
Rhythm is rate.
no.
No. Volume.
One is sequence.
One is
the
one is
sequence in
rhythm,
which it
another is
coming.
volume.
Another is irregularity in volume. That is also mentioned by being completely irregular. Okay. And do you think all the peripheral pulses are equally palpable? This is a very palpable, palatable comment. Can the radial and femoral be equal?
No, it will be equal with the corresponding
Why didn't
site
you
on the
say
other
that
limb.
all the peripheral pulses are well felt? That will avoid this confusion. Carry on. Apicocarotid delay is present. That is one very important information you have given. Carry on.
JVP, it is raised 5 centimeter above medial end of clavicle in sitting posture. A wave absent, extension absent. There is prominent CB wave. Respiratory rate is 24 per minute. Regular thoracoabdominal. Saturation is 98% in ambient air, and temperature is normal.
One question here. Is there any slowing of the in the upstroke of the pulse?
Sir, that I couldn't appreciate.
Fair enough. That is possible.
You
In
have
actual
mentioned about
situation,
prominent
it's
CB
difficult.
wave. What is the Y descent?
So the Y, there should be prominent Y descent, sir.
No, is it okay? There should be. So your mention is it's a prominent Y descent. And was there any slow downstroke or normal downstroke?
No, sir. There will be a normal downstroke.
Okay. Fine. Go ahead.
So
Next
should I go
one.
to-
Why this question was asked about the descent?
So regarding the RV function also.
No.
There
is a
patient is in
CV,
atrial
prominent
fibrillation.
CV wave
and
a slow Y descent. What does it mean?
With a slow Y descent, there will be associated some tricuspid stenosis or
There
tricuspid.
is some obstruction in the
obstruction.
tricuspid valve as well, right?
Hmm.
So you need to say about the Y descent whenever you tell about the CV prominent CV wave, immediately you should say about the Y descent. What is
And
the status? No,
you need not
normal-
explain because time is limited. But do you know what is H wave, capital H?
Capital H.
Okay. If you do not know, read it. Okay, go ahead.
দেখে নিস
হ্যাঁ।
এই ওয়েভ যেতে আজ জিজ্ঞেস করতে পারে বল তারপর বল
So systemic, going to the systemic examination, cardiovascular system inspection. Chest wall is normal in shape, bilaterally symmetrical. Precordial shape is normal. An impulse is noted in left inframammary region, likely apical impulse. No parasternal pulsation present. No suprasternal epigastric pulsation noted. No scars or dilated veins. Regarding the palpation, the inspectory findings are confirmed. The apex is in left 6th intercostal space, 2 centimeter outside the midclavicular line, forceful, well-sustained LV type. There is a grade 2 parasternal heave in the left.
Just a remark.
Yes, sir.
Nowadays, some of the examiners prefer inspection, palpation together. Okay, they do not go separately because on inspection we can't say many things. However, you feel the pulse of the examiner, whether he is happy with your presentation or looks to be somewhat that you are taking more time, not discussing together. So he may be asking, go ahead together. Okay.
It is always preferable to club them together, inspection and palpation.
Remain prepared. Okay, go ahead.
There is grade 2 parasternal heave in the left 3rd and 4th intercostal space. Diastolic fluid is present in the apical area. No palpable heart sound. Going to the auscultation, S1 is variable.
Okay, you told us that it is LV type. How do you differentiate between LV type and RV type?
Sir, LV type is more or less localized. There is not occupying more than one intercostal space. RV type is more diffuse, usually more than one intercostal space. LV type is associated with medial retraction, and RV type is associated with the lateral retraction.
Okay,
so from the palpatory findings, what is your interpretation? Up till now, whatever you have said.
So there is definitely a there is definitely cardiomegaly. So
yes.
So
yes,
I
go ahead. An individual chamber. After cardiomegaly, individual chamber.
The heart is overall is the LV is dilated. It has been moved down and out.
Don't say this way. You say there is features of both volume overload and pressure overload of left ventricle.
Yes, sir.
And what about RV? Comment upon RV.
And say about the RV.
So there is the grade 2 parasternal heave. So there is some RV eccentric hypertrophy as well, sir.
So RV pressure overload.
Pressure overload. You say that.
Subcostal palpation. Subcostal palpation.
Sir, I didn't get any epigastric or subcostal pulsation.
You didn't feel the RV? No, you couldn't feel the RV from the subcostal region.
I couldn't appreciate, sir.
You couldn't.
You then got a diastolic thrill over the apex.
Yes, sir.
What does it mean?
Indicating there must be
an associated mitral stenosis or
a significant mitral stenosis should be there, because a mild mitral stenosis rarely gives rise to a thrill. So it should be a very significant one. So how do you account for this parasternal heave now?
Associated pulmonary hypertension, sir.
Likely to be because of the pulmonary hypertension.
What hypertension? Pulmonary, arterial or venous?
Heart sound. Why?
No, one thing, RV means pulmonary arterial or venous. You have to say that.
Arterial.
Arterial. Because in the history, there is features of pulmonary venous hypertension.
Venous hypertension, yeah. And no palpable heart sounds. Is it expected in this case?
So since there is severe pulmonary hypertension, so
you are telling two things. Two things I will always expect. One is a palpable first heart sound, because This guy is having a mitral stenosis with a thrill, with pulmonary hypertension. I expect a palpable first heart sound and as well as a palpable P2.
Yes, sir.
Second heart sound in the left second intercostal space. These two things I will expect. You need to say why you are not getting it.
And another thing, besides these two, there are features of right-sided failure. Okay.
Yes, sir.
So another type of heart sound, additional heart sound, may be there. What's that?
There is a RVS3 or
Yes. So now I answer Dr. Bo's question. Could you get Dr. Bo's question or not?
yes, sir. Yes, sir.
Please answer.
Sir, I couldn't appreciate any palpable heart sound in the.
Is the patient very obese or fat? Very unlikely.
No, sir.
This
No,
type of
sir.
patients are lean.
Yes, lean and thin.
Yeah. So in that case, it is less like perhaps you should get it. You should examine it more properly, I think.
What are the
That is
features
one
of RVS3?
possibility. Other thing, anything else can obscure the sounds?
I'm sorry.
There might be some other systolic, the murmur ejection system murmur, which might obscure the sounds.
No.
No.
Was there any fluid around the heart or any pulmonary problem?
There are.
Pulmonary problem?
No, sir, but the patient being a smoker or also working in the being a carpenter with wood dust exposure might have some COPD, but patient is I didn't get any features.
Okay. So can you go ahead, Santanu?
Sure. Go ahead. These are the few things which will be asked during the exam.
Yes, sir.
And if the examiner is little meticulous, he will go and examine whether he is getting the palpable sounds. That is also you keep in mind. Go ahead.
And while palpating, you have to make him lateral as well as supine. Okay.
Yes, sir.
Not only supine. Okay, go ahead.
Sir, regarding the auscultation, S1 is variable, mostly loud. A2 is S2, regarding A2 soft, P2 loud, narrow split. There is no S3, S4. There is opening snap present. There is a low pitch mid-diastolic rumbling murmur, long murmur heard in the mitral area, localized, based audible at the cardiac apex with the barrel of the stethoscope in left lateral position at the height of expiration with pre-systolic accentuation, which is present even in the long cycle.
Okay, pre-systolic accentuation and atrial fibrillation. You discuss for 30 seconds.
Sir, because in case of a severe MS, there is the transmitral gradient is always very high. So there is so even in the short cycle, we expect a pre-systolic accentuation, and even if it is present even at the long cycle, then the MS is likely to be very severe.
And length of the murmur, was it varying or
it's
not?
It's a long murmur, sir.
Long murmur, I accept. Was it varying or not? Length.
Yes, it is varying murmur.
Okay. And how much could have been the O2 A2OS gap?
O2OS gap is likely to be varying but in here it is very narrow.
Narrow, always narrow. Okay, fine. Go ahead.
So there is a high pitch soft blowing, early diastolic decrescendo long murmur extending more than 50% of diastole, which is best audible in the sitting or leaning forward position in full expiration with the diaphragm of the stethoscope. The murmur is best heard at the left third intercostal space. There is a ejection systolic murmur of grade 3/6 intensity, mixed frequency, crescendo decrescendo in configuration with delayed peaking, best heard in right second intercostal space, radiating to both the carotids. Best audible with the diaphragm of the stethoscope, the patient leaning forward with the breath held at full expiration. There is a grade 3/6 high-pitched soft-blowing pansystolic murmur present in the left fourth intercostal space, heard with the diaphragm of the stethoscope, the breath held in inspiration. So these are the marmars I could appreciate.
About
So
the third
any
marmar,
other
about the
findings
third marmar,
here?
can you a bit elaborate more? Just go, yeah. Grade 3/4.
Grade 3/6. So there is a ejection systolic marmar.
No, you have written pansystolic.
The last marmar.
Oh,
Last
last marmar. Huh.
Third marmar, third.
So this is likely to be a marmar of tricuspid regurgitation.
Okay. So what was its behavior with respiration?
It was increased with respiration, sir.
Have you written that or told us? Oh, breath held in expiration. There is something different. Do you know
Do
what
you
is
hear
dynamic auscultation?
tricuspid murmur, regurgitation murmur in this fashion?
Actually, this is not a correct explanation for tricuspid regurgitation murmur.
Held, it has to be breath going on. With the inspiration, expiration going on, you have to listen to the character of
That
the
is
murmur.
exactly what I was telling. This is not the way a TR murmur is heard. A grade 3
Passive leg raising.
Soft blowing pansystolic murmur present in left fourth intercostal space, best heard with diaphragm with breath held in inspiration. Why? You hear it better during inspiration, not breath held in inspiration.
Patient should be continuing in the breathing, okay? Yeah. Then you note the behavior of the murmur, when it is increasing, when it is decreasing. That is known as dynamic auscultation.
Arindam got the point.
Yes, sir. Yes, sir.
You never mention it that I got it during held inspiration. No. You are comparing how the murmur is heard during inspiration versus how it is heard during expiration. And it is better heard during inspiration. That is what it is, what we expect. Question is...
Sir, may I comment? Sir,
yeah.
may I comment?
Yes, please, please.
Actually, dynamic maneuver in TR, we follow passive leg raising.
Yeah,
if the patient
that
is not
will
in heart
come
failure,
next.
I think
that will come next.
But from the respiratory.
First is about the respiration. Second, any other way you can know or no, that this is TR?
So with passive leg raising, the murmur, if the intensity of murmur increases.
Is there any change in the behavior of TR murmur with the onset and progression of RV failure?
Sorry, if the RV dysfunction progresses, the murmur might become softer in intensity because the pressure used to generate the TR might be lower.
Arindam, a few issues. Number one is, you say on passive leg raising, the murmur will increase. When? When
the RV function is already...
No. In absence of RV failure, I'm asking, if you raise the legs, it should increase within a bit or two immediately. If it increases after 6 to 8 bits, this can be a left-sided event. So that should be said, it increases immediately or within a bit or two, it increases. Second, what Arudha asked you about heart failure. What happens? You said the murmur will be faint. In overt heart failure, if the heart failure is severe enough, right ventricular stroke volume is not going to increase very markedly with inspiration. So this inspiratory augmentation will be attenuated. Okay.
Okay, go ahead.
So the other system,
please go ahead. Yes.
Yes. So the other system, trachea midline, chest bilaterally fine basal crepitation. So there, liver
limited only to the base.
Yes, sir. Limited only to the base.
Okay, fine.
Liver is just palpable below right costal margin, soft, no splenomegaly, CNS
tender, not tender, tender, not tender. These are the usual questions that we ask. That's why
mildly tender, sir. On palpation, there's mild tenderness.
What was the margin? It is sharp margin or rounded margin?
So it is a soft, rounded margin.
No, so on my queries, you are answering. This should come on spontaneously. When you are describing, another is just palpable. Okay, so that it mean that it was palpable during inspiration only?
Okay. Palpable after
ঠিক আছে,
taking.
বল এবার বল, তারপর কি?
Then you have to say what is the upper margin of the figure. Where is it?
The liver
অরূপদা, সময়ের সংক্ষেপ।
জানি ওলা চলে এসেছে প্রায় শেষে, সেজন্য।
হ্যাঁ, বল বাবা।
So coming to the
whether
final,
it is hepatomegaly or just palpability, that you have to define.
Yes.
All third year questions, okay. Clinics basically will remain to third year. Fine, go ahead.
Coming to the final diagnosis. This is a multivalvular heart disease, rheumatic in etiology, in the form of severe mitral stenosis, severe aortic regurgitation, severe aortic stenosis with tricuspid regurgitation, with severe pulmonary venous and arterial hypertension, in atrial fibrillation with controlled ventricular rate, in CCF without any features of active rheumatic or infective endocarditis, currently in NIHA class 3 on treatment.
ঠিকই আছে, তুই এবার জাস্ট কয়েকটা জিনিস চটপট বলতো।
Yes,
multivalvular heart disease, rheumatic etiology. Why do you say it is rheumatic in absence of rheumatic fever? Quick.
Because the chronology and the involvement of multiple valves and the most important causes in our country of mitral stenosis being rheumatic in etiology, and 50% patients would give
Multivalvular involvement, particularly also having a mitral stenosis. There, in this setup, there cannot be any other etiology. Very good. So why did you say it is severe mitral stenosis?
So there is a history of suggestion of severe pulmonary venous hypertension and
direct evidence of severe mitral stenosis.
And there is the heart points being that there is a mid diastolic long murmur. There is a opening. There is a variable but mostly loud first earth sound.
No, that is not an indicate. Doesn't indicate severity. Loud first sound.
There is a short A2OS gap and being a long murmur.
Then another point, very important, you said.
And the loud P2s.
No, that indicates pulmonary hypertension. You are telling something in the presystolic murmur.
Yes, sir. There is a presystolic accentuation which is present even in the long cycle.
Not accentuation. Presystolic murmur is being heard even in longer cycles.
Longer cycle. Yes, sir.
That is a very important point. Severe aortic regurgitation. Why?
Sir, the heart points in favor being there is a gross cardiomegaly, which is very unlikely in the presence of only stenotic lesions.
Be very brief, to the point.
So there is a long early diastolic murmur.
There is a long early diastolic cardiomegaly, long early diastolic murmur in presence of two obstructive lesions. Right. Severe aortic stenosis.
No,
why do you
no
say
peripheral signs.
No.
Why there is no peripheral signs?
So likely attenuated by the more proximal stenotic lesion, mitral stenosis, and also there is an associated severe aortic stenosis. So the peripheral signs has been masked by these two.
What is the clinical behavior of a patient if he is having mitral aortic stenosis and mitral regurgitation? In this patient, you have not mentioned mitral regurgitation. Just I am asking if there is association of AS with MR. What happens?
That would carry a very poor prognosis, sir, because there will
not only poor progression, it is a very quick progression. And you have not mentioned whether there is heart failure or not.
Yes, sir. The patient is in CCF on treatment.
CCF means whether it's left side or right side, both. You are meaning presence of both left-sided or right-sided biventricular?
Yes, sir. Both left and right-sided failures.
Okay.
You say severe aortic
stenotic, sir, double stenotic lesions, and yet your carotid upstroke, everything was normal. How do you explain that?
Sir, I found an apicocarotid delay, but the late peak, and there is a late peaking murmur also, but the slow rising I couldn't appreciate, sir. In presence of very low volume and atrial fibrillation, I couldn't appreciate
Okay,
the.
atrial fibrillation sometimes confuses it. Okay, you just say why that is. Did you say that is severe aortic stenosis?
So one, there is a symptom wise, there is a chest pain and there is a associated giddiness. There is apicocarotid delay and there is a late peaking murmur.
What was the length of the murmur?
It's a long murmur with delayed peaking.
How mitral stenosis influences the aortic stenosis murmur?
Sir, my mitral stenosis murmur would be, it usually attenuates.
It
It will
lessens or attenuates. But in this case, you are getting a long murmur. But mitral stenosis, you say it is very tight.
Yes, sir.
So how do you explain this thing?
So there is a associated aortic regurgitation also.
Very good. Associated severe aortic regurgitation is also there. That is perhaps lengthening the murmur.
I'm
You
asking
got
a
a
different, difficult question. You have enlisted 3 severe lesions: severe mitral, severe aortic regurgitation, stenosis combined. So what would be your sequence of placing them? Which one comes first? Which one comes second? Which one is third? All severe. How do I place it?
Sir, likely the mitral stenosis would be on.
He's asking
top.
you about the dominance of the lesions.
So the mitral stenosis will be the dominant lesion here, most dominant, as it is being the proximal lesion. It will affect the
Okay.
the
Next,
interplay
followed by
likely aortic regurgitation and then aortic stenosis.
So in the order you have written, and
Yes,
you have
sir.
got logic to explain that.
right.
So one is the development of the chronology of symptoms. Patient developed breathlessness with PND, and secondly, the patient developed palpitations, likely regurgitated lesions appeared. Then he went on to develop chest pain, but breathlessness would also occur in aortic stenosis.
So if you are thinking about the chronology is same and similar, why I'm asking this, initially, the mitral stenosis is a bit delayed in onset after the rheumatic fever, though there is no known history in this case. Suppose there has been an incidence of rheumatic fever. Mitral stenosis takes some time to develop. Mitral regurgitation develops immediately. It may heal, may not heal. And if it doesn't heal, it will progress. Aortic regurgitation come on immediately. It doesn't wait for the time. So this argument is not valid, that they develop in the same sequence. Got my point?
Yes, sir.
So how to treat this?
Any other thing you want to show?
So the ECG, X-rays.
Sure.
How to treat this patient?
So these patients with dual valve pathology likely would benefit from double valve. First, I would go for medical. Medical management
first.
Yes, sir. First, I would go for medical management. First, we would like to stabilize the patient.
By?
Sir, one is to first is the decongestion, give IV diuretics, go for the rate control. Then, since the patient is atrial fibrillation, I would like to go
with
for
what
some
you are going to
anticoagulation.
control the rate? Which drug?
Sir, we can go for beta blockers. We can go for digoxin.
Okay, combination, single, separate. Any problem with beta blocker initially, not later on?
Sir, first beta blocker, I'd like to titrate gradually because too slow heart rate can increase the severity of the regurgitation also of AR.
Okay, do you think that prophylaxis would help with this patient anyway, rheumatic?
Yes, sir. Prophylaxis, though there is involvement of 2 valves, but rheumatic because there is chance of the recurrence.
If you plan for surgery in the recent future, then is it going to help?
Yes, sir. There is a there will be chance of recurrence of rheumatic
It depends
results of
upon whether
carditis.
you are going for double valve replacement or single, or there are other things to be discussed. I'm not taking much of time. So your treatment part is finished. Any kind of other prophylaxis besides rheumatic?
Go for
Just asking why don't you go for aortic valve replacement only and do an OMC instead of going for double valve replacement? And you can go for the preservation of the
Very
body.
pertinent question.
Dipankar, here the question of double valve replacement doesn't occur. He has not mentioned about also. You will be going to this. You are absolutely correct. Question of DBR
Very
doesn't arise.
pertinent question.
So I think any prophylaxis besides rheumatic would you ask for this particular patient? You have to be very emphatic about infective endocarditis prophylaxis, even after valve replacement and before valve replacement. Okay. Then go to the surgical management, as Dr. Ghosh was asking, what would you plan?
So likely I'll go for surgical management, dual valve replacement in the same sitting along with the double valve replacement.
No. Why are you talking about again double valve? Dr. Ghosh warned you about this statement. Then even then you are saying, iterating the same thing. If I say, as Dipankar was suggesting, that you replace the aortic valve and do the mitral valve.
Repair the mitral valve.
What kind of surgery you think will help this patient? Is it OMC or CMC?
Sir, OMC.
OMC, because we are opening the heart.
Anyway.
So go for OMC.
Or how we can diagnose severe aortic stenosis in the presence of severe aortic regurgitation?
One is severe aortic stenosis would mask the effect. There will be systolic decapitations of the BP. Then it masks the
No, I'm not asking that. I'm asking, you have got severe aortic regurgitation, and what is the criteria you will take to diagnose severe aortic stenosis in the presence of severe aortic?
I'll just explain what sir is actually asking. Because once you have a severe aortic regurgitation, you tend to get a functional aortic stenosis as well because of the AR. Yes. So how much is the functional AS and how much is the organic AS?
Sir, the functional AS, how much I wouldn't.
No, I would explain further. After Dr. Pandey has asked, Dipankar has, suppose it is a mild mitral aortic stenosis. Even the presence of AR will make it to appear moderate to severe due to the regurgent volume again coming back through the aortic valve. Similarly, if it is moderate, even again it will be appearing severe due to the increased flow through it. So these you think over in this tune and ask, try to answer.
Okay. So the presence of aortic regurgitation would overestimate the AS, sir.
Absolutely correct. But what Dr. Pandey has asked you is how do you make this diagnosis of severe aortic stenosis in presence of severe aortic regurgitation?
So there will be the features of AS would be more like there is the apicocarotid delay, then there is the systolic decapitation, there is a delayed peaking murmur. If these are present,
you start from the beginning, clinical and investigations. In clinical, what are the findings? In investigation, what do you look for? In investigations, of course, one can identify, but in clinically?
So the symptomatology, there is associated chest
one is
pain.
Symptoms, very good. Then
symptoms of chest pain, apical impulse, there is a forceful, well-sustained
it should be a sustained apex.
Yes, sir.
Then
there would be
upstroke, pulse upstroke.
There will be delayed
carotid delay.
Yes, sir. And
About the second heart sound, if aortic second sound is audible, if you get a paradoxical second heart sound, obviously it has to be very severe.
severe AS.
So all these things comes together, and what is the when
And
it is
pulse,
speaking?
pulse pressure is
Also
important.
will be low.
Yeah.
So everything you need to say for clinical assessment. Then you tell about the investigational things. Right. I think Avik, you are here.
Just I want to
Yes,
see
sir.
the
Yes,
echo.
sir.
You can show
I-
show us the echo. The X-ray and ECG, just show the echo.
Arunda will be late.
না আমি ভিডিওটা খালি দেখতে চাইছি।
Okay, quick.
What is the LV wall thickness? Arindam?
Sir, LV wall thickness is around 12.
So do you think severe AS goes compatible with this?
Sir, I expected more LV hypertrophy, but due to associated critical MS, so.
But resistance doesn't go away with MS. Vijay?
I think AS developed later on. To begin with, it was MS and AR. And gradually the valve got stenosed and it could not get time to actually hypertrophy.
But he is above 40, I think.
Yeah, most likely that is the only explanation.
Another thing could be what you suspected at the outset. It is not a severe AS. Moderate. Because what was the criteria of severity in your assessment? Arindam?
So I said severe because because of the symptoms.
Okay,
like
besides clinics,
also,
now going to the investigation, what has been your criteria of severity?
Regarding the echo findings, regarding the AS, we have got the mean gradient, average mean gradient of around after taking 6 cycles of around 38 to 39 millimeter Hg. That too in the presence of critical MS and LV dysfunction. So it's likely to
LV dysfunction. Why do you say LV dysfunction in presence of severe MS?
So there is associated severe AR also and AS also.
No, maybe AR is there, but AR presence of AR doesn't explain LV dysfunction. You have to document it. What is the evidence of LV dysfunction? Because if you say breathlessness, that can be jolly well explained by MS, severe MS.
What was the ejection fraction?
Sir, around 38 to 40%, 39%.
No, looks like 50.
Okay, yes. There are certain things which remain unexplained. Do you think there is LA thrombus?
Yes, sir. There is spontaneous echo contrast, so we'd love to look for LA
So LV dysfunction will complicate everything. If the EAB is around 40%, getting a forceful, well-sustained apex, I think that's what you said.
Yes, sir.
So it will complicate things a lot.
Agreed, Dipankar. I fully agree with you.
Yeah,
Okay.
it will influence all the findings.
In fact, the regurgitation is not that severe. It looks like it's a severe MS with the severe aortic stenosis looking at the valve area, planimetry aortic area.
Planimetry aortic area, do you think is reliable in this case? It's already deformed, thickened, and so it has to be going otherwise. Your eye estimation about the planimetry of AVA. I think the exam is basically clinical. So if he can explain the things clinically, fine. It may not always be congruent with the echo and other findings. And on the basis of the echo, he may have to revise his diagnosis. That scope we always give. Okay, what is your opinion, Shaturu? Do you give that scope or not?
Always, because the
Always.
first, let us see the clinical aspect first.
Because on the bedside, we also make many errors. Many things remain unexplained. I think Dipankar has grown up enough by this time. He will also agree.
Fully agree, sir. Fully agree, sir.
So it is time to go
We
to
diagnose clinically need not corroborate exactly with the investigations, and it does not corroborate, to be very honest. There are things which goes this way or that way, and you need to explain those things. Anyway, Arindam, good case.
So
Good
one
case.
last question. One last question.
Yeah,
Can there be chest pain?
Arindam, very nice presentation. Very nice presentation.
Another
Can
thing
there
he
be
did
chest
very
pain in
well in
severe
the
aortic
ECG.
regurgitation?
Yes, sir. Might be nocturnal angina in aortic regurgitation, and also due to aortic regurgitation patients usually complain of nocturnal angina, and chest pain is subjective, so most patients also complain.
Another comment, Arindam did very well in ECG also. Good pointing out. So particularly presentation and facing this kind of challenges help a lot during exam. Avik, what do you say?
Yes,
by
sir.
your experience, facing challenges, particularly presenting many cases even in front of students, help you a lot.
Exactly.
Yes, are you ready, Avik?
Yes, sir. Yes, sir.
Arindam, thank you very much. I think we could have discussed for quite some more time, but for the lack of time, we need to end it at this point here. And thank you. Thanks for a very nice
Arindam,
presentation.
last word from my side. During exam, if the number of candidates are less, be prepared for longer discussion in your long case, and that decides everything, whether you are going to pass or not.
Arindam, unshare the screen.
Okay. Thank you. Avik, please, Arindam, please unshare your screen. Avik, start.
Yes. So I hope I'm able to, my screen is visible.
Yeah.
So unfortunately, I'll be showing the slides, but I'll be showing the videos separately because it's not playing from my laptop. So I'll be presenting a case of peripheral arterial disease, an interesting one. So the patient was a 28-year-old female, had presented with a refractory hypertension. The blood pressure was 184/90 mmHg in the right upper limb with 5 medications. It's telmisartan, amlodipine, chlorthalidone, prazosin, and bisoprolol. The patient also had a history of buttock claudication, left more than right, Fontaine stage 2B, that is a moderate to severe claudication history. Patient also gives a history of 2 spontaneous abortions in the first trimester over the last 2 to 3 years. On examination, there was radiofemoral delay present, and the left radial ulnar and the brachial artery pulsation were absent, and the other pulses were symmetrically palpable. So the basic investigations that were done, including renal function, thyroid, USG were normal. EKG showed a left ventricular hypertrophy with strain pattern, and echo showed a gross LVH with a normal LV function. Urine for ACR showed a microalbuminuria. A CT angiogram of the aorta and its branches were done, which showed a normal ascending arch and descending thoracic aorta. The left subclavian artery was occluded with distal left arm supply from collaterals. Other vessels of the artery were also normal. There was diffuse narrowing of the infrarenal aorta with aortoiliac bifurcation lesion with significant narrowing involving the origins of both the common iliac arteries. The rest of the lower limb vessels were normal. Unfortunately, this was not able to explain the refractory hypertension if we were, as we were thinking in the same line because of the multiple peripheral arterial involvement. We were also suspecting some form of a renal artery involvement also, or some sort of a suprarenal aortic involvement, but unfortunately it did not reveal.
What is your clinical diagnosis?
So basically, sir, we were thinking about an aortoarteritis in this patient.
So in aortoarteritis, even in absence of renal artery stenosis, hypertension can be there.
Yeah, definitely. Definitely, sir. But again, we were wanting to rule out a renal artery involvement. If it was there, it could explain, or some form of a suprarenal aortic involvement, which could explain. Because other than that, only medical management is left, which is already the patient is gone, and we were gradually operating the antihypertensive medications. So,
what was the ESR? What was the ESR?
So ESR and CRP were both normal.
Okay, fine.
Yeah. So we did an angiogram by the right femoral artery route. The coronaries were normal. The left subclavian artery was occluded. The left renal artery had two branches. The right upper renal artery was showing an osteostenosis, but it was a very small caliber. The other branch was, the major branch was normal. The right renal artery actually had three branches. The right superior branch had a 95% stenosis of the ostium, and it had a very bad takeoff from the aorta. The other two branches were normal. And there was narrowing of the juxtarenal part of the abdominal aorta with the aortoiliac bifurcation lesion with more than 90% stenosis of both the common iliac arteries, that is task type D. I'll just show you the videos. So this was the left subclavian artery, which was totally occluded immediately after the left vertebral artery. And the left vertebral artery also had a significant lesion. And this was the renal part.
No, just one moment.
Yeah.
The injection into proximal subclavian artery, we have seen the vertebral, but proximal subclavian, no, proximal to the vertebral origin.
That was also diffuser disease. There's also disease.
Okay, so what was the site of the lesion?
The lesion is basically from the origin itself, but it was totally occluded after the origin of the vertebral artery.
Okay, because that is not shown, that's why I'm asking.
Yeah. So this is the renal part. We took a DSA, which showed a significant narrowing of the right upper renal branch with a 95% stenosis involving the ostium, and it had a very bad takeoff from the posterior aspect. The other two branches were normal. The lower part also had a stenosis, but it was of a relatively narrow caliber. The left one, the left upper one had a disease, but it was of a small caliber. The left major renal artery was
But that was supplying the lower pole.
Yeah, that was supplying the lower pole, but originating superiorly.
So there is sufficient reason to be multiple rise in renin.
Yeah, exactly. So now what to do? The blood pressure gradient, suprarenal aortic pressure was 170/80, and the right femoral artery had a blood pressure of 110/80. So definitely the stenosis was significant. Now what to do? How to manage this patient? We gave the option of a surgical renal and aortic bifemoral bypass, or an endovascular approach with a PTRA with an aortoiliac bifurcation stenting. But the patient party vehemently refused surgery. They did not want surgery by any means. So they constantly asked her to do something percutaneously. So now we went ahead with the PTRA with an aortoiliac bifurcation stenting. What my
As it is the
principle
case
was,
of aortoarteries, Avik,
yeah.
Can you think of doing plain balloon, and if dissection occurs, go for stenting?
Sir, yes, that is definitely was a consideration to think. But if you look into the lesion, it was a
It
very
appears
bad,
that they will definitely do.
yes. That was a very bad
I accept your point.
So, and especially the aortoiliac bifurcation part is again a very dangerous part to leave it without.
I accept your point, but just I wanted to convey the message to the audience that in aortoarteries, certain arteries can be dilated without.
Exactly, absolutely. So now, now what happened is we needed a bifemoral approach for this procedure to be done, but unfortunately, when palpating, there was the left femoral artery was not being able to be palpated properly. So we had to modify ourselves, and we had to use a angiogram guided puncture of the right femoral artery. So we did a angiogram of the right.
Of Doppler guided puncture?
Sir, unfortunately, the echo machine was not there in our cath lab at that point of time.
But can you bring it if necessary? You are working in a big hospital. So peripheral Doppler.
Yes, sir, but actually, Yes, sir. But because already the right femoral artery was already cannulated, and we had the option of going and doing a
No, that just decreases the contrast load. That's why I'm not telling. Okay, okay,
yeah, that
fine.
is definitely. But again, we did this, and luckily we could puncture it successfully, and the puncture was again successful.
Is there any junior student? Because there are certain teaching points in the puncture. Shantanu, junior ছেলেরা আছে?
আছে. You can go ahead.
Because yeah, I think you can show them which point you select for the puncture, because after the angio you have seen, you are going to overlap your needle on the artery. Okay.
Yeah, exactly.
So which side do you prefer for your puncture?
Right. I'll just play the video again. So the approach should be the puncture should be on the femoral head. So that is our main principle. So
no, you have to be more specific, not on the femoral head, but one quadrant.
So
if
in
you
the
go for the upper quadrant, that will be dangerous.
Yeah, right.
You have to be in the lower quadrant.
In the lower quadrant, the puncture should be there, and it should be on the femoral head.
Yeah.
So everyone
you have to be always below the inguinal ligament at the puncture point.
Yeah, right, absolutely. So next, after that, now we went ahead with the PTRA. We used a 7 French RDC catheter and a floppy wire. And probably the wiring of this renal artery was one of the most difficult things that I faced during the entire procedure, because it was very difficult to wire, because all the time the wire was constantly going into the main renal artery, the bigger one, and we were not able to cannulate the desired renal artery as we
Did you take any other view besides this frontal view?
So this was a modified view which we had taken a slightly
this is an oblique view,
which showed
different. One second, Devjit.
And so basically what we did is we kept a wire in the the bigger branch of the renal artery, and so that the guide catheter was not getting dislodged, and ultimately after a lot of time we could manipulate into the right upper renal branch successfully.
So did you try through PTCA wire or some other wire?
We used a PTCA wire because the renal stent that we were using was 014 compatible. So we used a floppy wire for wiring the upper renal artery.
Okay.
So
it's a lot of torquing the PTCA wire. So did you use the PTCA device that we use proximally?
It's a insertion tool. Yeah. Insertion tool. I had
the Y connector.
Yeah, sir. Everything was there, but unfortunately, what was happening is because of the very bad orientation. So whenever
problems are there, but people, I'm just telling these things to clarify to the other boys who may want to do this type of case. So be ready with everything as you are doing a PTC.
Yeah, exactly. So luckily, after a lot of time, I could wire that renal, and after that, I passed the other wire also into the branch for better support. So after this, we went ahead with the pre-dilatation. We used a coronary balloon, 2x10, followed by 3x12 mm NC balloon at 18 to 20 atmospheric pressure. So we dilated the lesion appropriately with a serial dilatation initially.
What was the approximate diameter of this artery? This is a smaller artery.
About 6 millimeters, sir. 6 millimeter diameter.
Fine.
Almost. So after an appropriate dilatation, we went ahead and took the renal stent. It was a 6x18 millimeter Herculean Kellet stent of Abbott, and it was deployed at 12 atmospheric pressure, and further ostial flaring was done with the stent balloon itself. So
you did it at a higher pressure?
Yeah, the deployment was done just a bit higher above the nominal pressure, and followed by that ostial flaring was done at about 16 atmospheric pressure. We did not further post-dilate the lesion.
Okay.
Though there was a significant residual stenosis, but it was acceptable for us at that point of time. So after this, so this is our angiographic result after stenting
Shantanu,
of
do you
the.
have some time to discuss? Shantanu আছে? Because এখানে সময় নেই,
Not much
otherwise
time is there. It is
না,
already 10.
just একটা point আমি মাথায় ঢুকিয়ে দিচ্ছি অন্যদের শোনার জন্য. I think everybody understands Bengali, that the use of the protective device and not to use a protective device, etc. In this case, they have not done it. I do not criticize that because debris is not much here. Fibrosis is much more. But in atherosclerosis, there is a lot of controversy with this. Please, Avik, go ahead.
Sir, after that, then we went ahead with an abdominal aortic stenting and the bifurcation stenting. So what we did is we planned to use 3 stents, 1 stent to deploy in the infrarenal part of the aorta above the bifurcation, followed by a simultaneous kissing balloon, kissing stenting using 2 stents in the aortic, iliac bifurcation to cover that up.
Simultaneous, do you have that picture?
Yes, sir, I'm showing you. I'll show you. So initially we took, we thought about dilating the renal infrarenal part of the aorta. We used a 7 into 60 mm pre-dilatation balloon. So pre-dilatation was done of the infrarenal aorta, followed by we also dilated the right common iliac artery also simultaneously. After that, we took a stent. After that, we took a 10 millimeter into 10 millimeter into 60 millimeter absolute pro self-expandable stent, and
These measurements were based upon what? Your
angiographic measurements.
Angiographic.
Yeah.
Okay.
Yes, sir. So after that, we successfully placed or deployed our abdominal aortic stent, and it was a good deployment. Sorry. So this shows a good deployment. So after once we had deployed it successfully, this shows a good deployment of the abdominal aortic stent. After that, from the left femoral artery, we had to recross into the through the stent distally. We used PTCA. We had to use a PTCA wire, followed by we passed a JR diagnostic catheter, followed by the Termo wire for our further proceeding.
So what was the final catheter?
Sir?
After
Sorry,
passing the Terumo, what was your final catheter?
So
on
we did not use any catheter because the stents were 035 wire compatible. So we used the stents over
these were balloon expandable or self-expandable?
So self-expandable stents.
That is why this was possible.
Yeah. Yes, sir.
Okay. This is also described in common Indian language as pajama stenting. I was
exactly. So we serially pre-dilated the common iliac arteries on the right side, followed by on the left side also we pre-dilated it, and after that we took 2 stents. After that, we took 2 stents. For the left common iliac, we took an 8 into 60 mm absolute pro stent, and for the right common iliac, we took a 9 into 60 mm absolute pro self-expandable stent, and we positioned it with adequate overlap with the abdominal infrarenal abdominal aortic stent. We positioned it at the same point, and this was our positioning with adequate overlap in the lower part.
Here, the radiographic assessment is very important because you cannot give any dye at this time.
So, sir, at this point
you
of
should
time,
have assessment from beforehand, from where to do
exactly.
it. Yeah.
So, in this point, the image shows that we initially deployed it to see the initial location where it is getting deployed, and we were satisfied with an adequate overlap with the abdominal aortic stent. So once we were satisfied that the position of the stent was okay, then we completely deployed the stents, and there was a good deployment of the stents bilaterally.
Did you have to balloon after the self?
No, sir, because it was a self-expandable stent, we did not balloon it post after the procedure.
No, at times it is required. That's why I'm
Yes,
asking.
sir, at times it is limited, but the
Because
flow
the
was.
radial pressure strength may not be adequate with the self-expandable.
Yes,
Then you need a balloon post-dilatation.
So this
I
was
think
our
it is a
final
very
result.
good demonstration, very good demonstration. And what did you do with other minor renal artery branch stenosis?
Sir, other minor things we did not address that much because those were relatively smaller vessels and
You are backing up on medical therapy. That's it.
yeah. So luckily, in 3 months follow-up, and so after the procedure also, sir, there was the pulse pressure was equalized in both the femoral arteries with the suprarenal part of the aorta. And at 3 months, the patient is presenting with us. The patient is not having any claudication. The blood pressure is 130/80 with only 3 medicines: telmisartan, amlodipine, and chlorthalidone. And chlorthalidone also, the dose has been reduced to 6.25 milligram. And we plan to change telmisartan before attempt for.
What is the age of the patient you told?
Sir, 28 years.
28. So they are planning for pregnancy.
Yeah, yes.
So do you know the status of the internal iliac arteries? You know why I'm asking?
No, sir. The rest of the internal iliac arteries, we had taken the angiogram. It was normal. The rest of the vessels were normal.
That is very important to know.
Yes, sir. That we had seen
And
before.
another thing, that if it is a renal arterial stenosis isolated, anything else is not there. After dilatation, there could be precipitous fall of BP. So you have to be quite careful regarding usage of antihypertensive drugs.
Exactly.
Pre, intra, and post-op.
Yeah, yes, sir.
Very good, very well done. Who were in the team? Yourself and?
Sir, I did this case in medical college.
Okay. Alone or with somebody else?
Yes, sir, I did it alone.
Doctor,
and Arindam was there. Arindam was there during the procedure also.
Dr. Avik, just asking.
Yes, sir.
Just asking, when you knew that this is a case of peripheral arterial disease, why did you give bisoprolol initially as a part of the antihypertensive regime?
Sir, bisoprolol was not given by us. It was given beforehand from outside. We had changed the drug to nebivolol. But unfortunately, it was not getting controlled. Though I did not mention that. I just mentioned the drug history.
Bisoprolol, doesn't make.
That's a very good presentation.
There is proximal stenosis in the large arteries. And these are fixed changes. So vasodilation part doesn't work.
Yeah, that's also true.
Actually, beta blocker are not absolute contraindication.
Exactly.
In peripheral arterial disease. So fantastic case, Avik. I have just one query. Why didn't you post-dilated the right renal artery stent?
Right renal artery stent. Okay. That is right. But unfortunately, the answer is we did not have the adequate size post-dilatation balloon.
Okay.
Arindam, this is the real life scenario in government sector.
So I accept whatever, no problem.
Yeah.
Okay, good case.
Very good case. Lot of claps.
And you need an appreciation. So thank you very much. All the speakers, Aditya is not here. Arindam and Avik, you did a wonderful job. And we had a very good discussion. Now, we'll be having this type of the study cycle meeting. So once in a month. So we'll have it sometimes in December, and we'll intimate you adequately in advance so that you can block that time and join. I request everybody to join the next meeting as well.
একটু আগে থেকে বলে দিলে আমরা সন্ধ্যাটা ফ্রি রাখবো আজ এইবারে আমার সন্ধ্যাটা
I will intimate at least 10-15 days earlier.
Okay, thank you so much.
I have a very small suggestion. As this is whatever I observe, I actually went back to my DM days. So this will be very, very helpful for the DM trainees and DNB trainees. So if you include all the students who are actually pursuing DM and DNB across different medical college and private institution, then it can be a very good platform for them as well. In fact, some people, if they are hearing, they can actually go and include the students in this forum So that will be very good platform for them for continuous learning.
Arindam, for your information, we have invited everybody, all the DM and DNB students across all the teaching centers in Calcutta. So many of the, I think we could not reach all of them, but we tried
Yeah,
to reach.
I think
try to
private
visit-
institution were not reached because I did not see any DNB participant. In fact, in my hospital there are 2 DNB trainees, so it will be very good for them as well.
So
RN
I
Tagore,
would
Apollo.
want to intimate them and tell them
Yes,
to
yes.
get in touch with me or yours. You can also incorporate their phone numbers in the WhatsApp group, and
Yes,
so
yes,
that they get the intimations. I request everybody to intimate their respective students so that they can join.
I'll
And
be a perpetual student, Shantanu. Don't worry. I'll be a perpetual student for you.
Okay, then.
Okay.
Till then, good night.
Good night.
Good night, sir.
everyone.
Good
And
night. Good night,
Shantanu,
everybody.
special thanks to you for organizing such a beautiful event.
No, nothing. It's my pleasure.